And now getting into rounding, you know, it's internal medicine rounding is known for being excessively long. So, you know, take care of yourself. You know, sit when you need to, eat a snack when you need to go to the bathroom, eat, drink water, things like that. And you know, even though it's known to be long, don't let rounding don't let it be an excuse for you to make your presentations excessively long or boring or like, you know, don't include way too many details. You know, try to keep your presentations focused and concise. And you know, a way that can help with that is just, you know, really jot down bullets, and have some notes with you to go through in an organized fashion. What things do you want to mention? Because if you're going to mention every single thing that's ever happened to that patient while they're in the hospital, or if you're going to read the entire progress note, it's gonna take way too long. And so, you know, people have pretty short attention spans. You know, you can't keep everything in your memory at the same time. So just, you know, kind of use your memory, use notes as kind of a limit of how much you should be kind of sharing about the patient in terms of how they're doing, what your plan is, and things like that, to help guide your presentations and prevent them from being too long. And if your attending or resident asks for more information and you didn't check it, just say you didn't check it, be honest. Don't try to make up information or physical exam findings on the spot. If it's an important piece of information, just make sure to keep track of that information in the future. So for presentations, I'll share a generally accepted approach, but be prepared if your attending prefers presentations in a slightly different way, such as presenting only pertinent information. Then you would get rid of, you know, you would kind of make it more concise and get rid of all the really like normal findings, and you just kind of focus on things that are abnormal or things that you're following and tracking. So a quick kind of overview of presentations. I think a pretty common format for them is starting with a one-liner, and then getting into overnight events, subjective, vitals, physical exam, labs, imaging, and then the assessment and plan. So essentially a SOAP format, but this is just kind of telling you the details for what that means on rounds. And so, you know, starting with the one-liner, that sets the stage. It reminds people, who are you talking about? You know, there's a list of like, you know, 18 patients. You know, we got to jog people's memories, let them know who's being presented on. So, you know, an example of this is, you know, let's say Jane Doe is a 70-year-old female, history of COPD and 60 pack years of smoking, admitted for acute hypoxic respiratory failure. Overnight events, you know, you can state these. If there's nothing, just say no acute overnight events. You know, pro tip, you can mention some major studies here and then repeat them later in designated sections. This is kind of a stylistic thing. You can do it or not do it, however you like. So, you know, no acute events overnight. Her CTPE was negative. Subjective, you know, how are they doing today? This is kind of like your pre-rounding. You know, what you talked about, and, you know, keep this pretty short. You can expand in your progress note. Miss Doe was she said that she was feeling pretty well this morning. She says that her breathing has been improving with the nebulizer treatments, but she's still feeling short of breath when walking to the bathroom. No fevers, chills, or chest pain. And then go into objective, you know, doing vitals. You can add intake and outtake here if you're tracking it. Objectively, her vitals are temperature 37 Celsius, heart rate 86, respiratory rate 20, blood pressure 120 over 80, satting 92% on 2 liters nasal cannula. Physical exam, she was breathing comfortably with the nasal cannula. Her lungs were still diffusely, you know, had diffuse expiratory wheezes and low inspiratory volume. Heart rate with regular rates, no murmurs. Abdomen was not soft, non-tender, non-distended. There was no lower extremity swelling or redness. For labs, you know, provide some context how it compares to yesterday, if it's abnormal or if it's changing and you're tracking it. Labs notable for sodium 134, down from 135 yesterday. Hemoglobin 12, which is steady from 12 yesterday. White count 6, her strep pneumo antigen was negative. So imaging, you can provide just a quick sentence about this. You don't have to say the whole report. CTPE was negative, though with emphysematous changes. Chest X-ray showed no signs of consolidation or effusion. EKG was sinus tach, no ST elevations, depressions, or T-wave inversions. And then getting into assessment and plan, start this with a one-liner, and that kind of summarizes the patient, and then get into, summarizing the patient's condition, requirements, and expectations, basically the most important things that are keeping the patient still in the hospital. You kind of want to summarize there. And then summarize, transitioning to this part, you can start with a transition word like my assessment is that, or in summary, or for assessment and plan, something like that. So, a quick example of this is, my assessment is that Jane Doe is a 70-year-old female with a past history of COPD and 60-pack years smoking, who was admitted for acute hypoxic respiratory failure secondary to COPD exacerbation, currently improving with DuoNebs, azithromycin, prednisone, though still requiring 2 liters nasal cannula. She'll likely be able to discharge home in the next 1 to 2 days once her oxygen requirements resolve. So this is kind of like a global assessment. And then you get into your plan part. And then your plan, you want to note the status. Is this problem improving or getting worse, or is it stable? And then a helpful framework to cover all of the things you want to talk about in a plan is DDX, DX, and TX. DDX meaning differential, DX meaning diagnosis, and then TX meaning treatment. So, what is your differential? What further studies are you doing for the diagnosis? And what are you doing to treat the disease? That helps you cover all the things you want to talk about in your plan. And you can just mention this for the acutely things that you're actively managing. You don't need to, orally present all the chronic conditions that someone might be there with if you're not doing anything for those. Let's see. Yeah, so for example, let's say problem 1 is she has acute hypoxic respiratory failure, acute hypoxic respiratory failure secondary to COPD exacerbation. This appears to be improving. She's decreased her oxygen requirements from 4 liters to 2 liters now. And there's been an unclear etiology for exacerbation. Her differential includes viral infection, medication non-adherence, environmental factors, or progression of disease. Plan for treatment for her is to continue the DuoNebs Q6 hours, prednisone 60 milligrams for 5 days total, azithromycin 250 milligrams for 5 days total, home inhalers, and then weaning the oxygen as tolerated for a goal O2 sat of 88 to 92%. And then for her type 2 diabetes, her A1C was 7.5 on admission, and so we're continuing her on sliding scale insulin for that. And then as a little tip for presentations, and possibly anticipating any questions you may be answered about them, you can share any important literature or clinical pearls you learned about while kind of learning about how to treat certain things. And if you learn certain things that are really helpful to the whole team, share it with the team. These can be really helpful for other people to learn and listen to. And then, in terms of anticipating certain questions you may be asked, think about, why is azithromycin used for COPD exacerbation if, most exacerbations are caused by viral illness and azithromycin is an antibiotic, right? So, thinking about questions like those and anticipating those can help. So a quick word about assessment and plan. Start with the one-liner and then go into this global assessments of how their status is. Assessment and plans, they can seem really confusing and people can get lost very easily because it feels like you have these kind of 2 parts of assessment. You have an assessment kind of at the start and then you assess each of the problems. But so think of it like this. Think of it as starting with a global assessment of how their overall status is. Are they overall stable, worsening, improving? You can include more details like improving but still requiring 2 liters of oxygen, or improving but still remains intermittently febrile. And you can speak to tentative discharge thoughts here, or you can save that for the end of the presentation as well. So after the global assessments, then you do an assessment and plan for every single problem and start with the most active problems. So, I talked about the structure, ddx, dx, tx can kind of help make sure you're not forgetting certain things about like differential. What further studies do you need to diagnose it? What are you doing to treat the disease? And don't be afraid to ask questions. I think there's a pressure to be as independent as possible, but don't be afraid to ask questions here, especially in your assessment and plan, where there's a lot of kind of knowledge that's needed from the resident or from the attending from their prior experience. And just so ask the resident, ask the attending, don't just agree about decisions being made about your patients. Ask them why certain decisions are being made and learn from that.